Hello and welcome back. Right then, let's get stuck into part 2 of our deep dive into anesthesia for patients with respiratory disease. In this session, we're really getting into the sharp end of things, tackling some of the most complex and challenging scenarios we face: restrictive lung disease, problems with the chest wall itself, and then moving into the critical care world of acute respiratory failure and ARDS. Welcome to the Anesthesia and Perioperative Medicine channel. Bienvenue sur la chaîne Anesthesia et Médecine Perioperatoire. Willkommen im Kanal für Anästhesie und Perioperative Medizin. Bienvenido al canal de Anesthesia y Medicina Perioperatorio. So what have we got on the cards for this explainer? Well, think of it as a journey from the ground up. We'll start with the fundamentals of restrictive lung disease, really getting to grips with what that means. Then we'll look at what happens when the problem isn't the lung itself, but the structures around it, the chest wall and mediastinum. After that, we ramp things up to talk about acute respiratory failure and ARDS. And that leads us perfectly into a discussion on modern lung protective ventilation strategies. We'll wrap it all up by looking at the very latest guidelines for managing the toughest of them all, sepsis-induced ARDS. It's a lot to get through, so let's get started.
Okay, first things first, restrictive lung disease. Now, if you remember from part 1, obstructive diseases like COPD are all about the difficulty of getting air out, while restrictive disease is the exact opposite. The problem here is getting enough air in. The lungs simply can't expand properly, which means all your lung volumes, your total lung capacity, your vital capacity, they're all reduced. The core issue is a loss of compliance. Imagine trying to inflate a stiff old car tire with a bicycle pump. That's restrictive lung disease. The lungs are stiff, they fight you at every turn, and it takes a lot of pressure to get even a small amount of air in.
So, what causes this? Well, you can split the causes into two big buckets. On one hand, you have intrinsic problems, where the disease is in the lung tissue itself. This can be acute, like pulmonary edema, where the lungs fill with fluid, or chronic, like the scarring and stiffening you see in pulmonary fibrosis. On the other hand, you have extrinsic problems. Here, the lung tissue might be perfectly healthy, but something outside the lung is physically stopping it from expanding. Think of severe kyphoscoliosis crumpling the chest wall, or massive ascites pushing the diaphragm up into the chest. Even things we see every day, like obesity or late-stage pregnancy, act as an extrinsic restriction. Let's drill down into acute pulmonary edema, because figuring out the why is absolutely critical. Is it a heart problem or lung problem? Well, this algorithm gives us a brilliant way to work through it. First, look at the patient in front of you. Is there a story of aspiration or sepsis? That points to non-cardiogenic or permeability edema, where the lung capillaries are leaky. Or is there a history of a heart attack with a classic S3 gallop? That screams cardiogenic. Next, the chest X-ray. A normal-sized heart with fluffy infiltrates out in the peripheries suggests leaky capillaries. A big, baggy heart with central batwing edema and curly B-lines, that's classic heart failure. And if you're still not sure, advanced monitoring gives you the final answer. A low pulmonary artery occlusion pressure, under 18, with good LV function means it's the lungs. A high pressure, over 18, with a failing left ventricle means it's the heart. So when you're faced with a patient with chronic fibrosis, what's the one thing you need to have front and center in your mind? It's this: these patients have absolutely zero physiological reserve. Zero. Pre-op, if their vital capacity is less than 15 mils per kilo, that's a massive red flag. Intraoperatively, the challenges are huge. Their functional residual capacity, their oxygen tank if you like, is tiny. This means when you induce them, they will desaturate frighteningly fast. Apnea is not their friend. That small lung volume also means inhaled anesthetics get taken up much quicker. But the biggest danger is barotrauma. Their lungs are stiff and fragile, like old parchment. You have to be incredibly gentle with your ventilation to avoid causing a pneumothorax. All right, let's shift our focus a bit. We've talked about diseases inside the lungs. Now let's look at conditions where the external structures, the chest wall, the pleura, the mediastinum, are the main problem. These extrinsic restrictions bring their own set of unique challenges. For example, a patient with muscular dystrophy has profound muscle weakness, and our anesthetic agents can tip them over the edge into postoperative respiratory failure. So we really need to be on our toes.
Flannel chest is a dramatic example, usually after a major trauma. You've got multiple ribs fractured in multiple places, creating this free-floating segment of the chest wall. When the patient tries to breathe in, that segment gets sucked inwards, and when they breathe out, it bows outwards. It's called paradoxical motion. But you know what? The real problem isn't usually the paradoxical movement itself. It's the excruciating pain, and even more importantly, the underlying pulmonary contusion, the bruised lung beneath the fractures. That's why many of these patients need to be intubated and ventilated, not just for oxygenation, but to use the positive pressure to act as an internal splint to stabilize the chest wall. Okay, a quick thought experiment for you. Picture this. You're anesthetizing a trauma patient. You don't know it, but they have a small, simple pneumothorax. You induce anesthesia. You start positive pressure ventilation. In that moment, what is the single most critical, most life-threatening complication that can happen? The answer, of course, is a tension pneumothorax. This is one of the true anesthetic emergencies. What happens is the positive pressure from your ventilator forces air into the pleural space through the hole in the lung. But a flap valve effect can develop, meaning air gets in, but it can't get out. It's a one-way ticket to disaster. The pressure builds and builds, squashing the lung, then pushing the whole mediastinum across, kinking off the great veins and causing catastrophic cardiovascular collapse. And this is the drill we all need to have burned into our brains. The moment you suspect a tension pneumothorax, sudden hypotension, hypoxia, high airway pressures, maybe a deviated trachea, the first thing you do, the very first thing, is disconnect the breathing circuit from the endotracheal tube. Stop forcing more air in. Step 2 is to immediately decompress the chest. Get a large bore cannula and put it into the second intercostal space in the midclavicular line. You should hear a hiss of escaping air. This is a temporary fix, but it's life-saving. It buys you the time you need for step 3, getting a proper chest drain put in.
Now, moving from the pleura into the middle of the chest, the mediastinum, there's a very specific high-stakes risk during a procedure called a mediastinoscopy. The surgeon puts a scope down behind the sternum to biopsy lymph nodes. The problem is, the innominate artery, which supplies blood to the right arm and the right side of the brain, runs right through that area. It is frighteningly easy for the scope to compress that artery. If that happens, you'll lose the right radial pulse or see the arterial line trace dampen. That's why continuous monitoring of that right-sided trace is absolutely non-negotiable. It's your only warning that you're losing blood flow to the brain.
So we've gone from a very specific mechanical risk to blood flow to our next topic, a global physiological catastrophe. We're talking about acute respiratory failure and the acute respiratory distress syndrome, ARDS. This is the final common pathway for a whole host of different insults to the body. It represents a profound inflammatory storm that leaves the lungs devastated, and it is the absolute peak of critical illness for the respiratory system. This table is really useful because it splits the causes of ARDS into direct and indirect injuries. Direct injuries are the obvious ones: pneumonia, aspirating stomach contents, a direct blow to the chest. That makes sense. But the concept of indirect injury is so important. This is where the lungs are the innocent bystander. You can have a perfectly healthy pair of lungs, but severe pancreatitis or sepsis from a perforated bowel can unleash a firestorm of inflammatory cytokines that circulate through the body and attack the lung capillaries, causing a full-blown ARDS. And of all of these, sepsis is far and away the most common cause we see in the ICU.
So how do we actually diagnose it? Well, we use a set of criteria known as the Berlin definition. It's a checklist of 4 things. First, the timing. It has to be acute, developing within a week of a known insult. Second, and this is the hallmark, is severe hypoxemia that is refractory to oxygen. We quantify this using the PA2 to FiO2 ratio. Third, you need to see bilateral diffuse infiltrates on the chest X-ray, the classic whiteout. And finally, you have to be confident that this whole picture isn't just due to heart failure or fluid overload.
Right. So you've diagnosed ARDS. What now? This brings us to the absolute cornerstone of management: mechanical ventilation. And our whole approach to this has been completely revolutionized in the last 20 years. We've moved away from just thinking of the ventilator as a machine to keep people breathing. We now see it as a powerful therapeutic tool that, if used incorrectly, can cause enormous harm, but if used correctly, can actively protect the lungs and give them a chance to heal. And this slide just sums up that paradigm shift perfectly. The old way, the goal was simple: make the blood gases look normal. To do that, we used huge tidal volumes, 12, even 15 mils per kilo. The problem is, in ARDS, only small parts of the lung are actually aerated. So we were just overstretching those few good bits of lung to breaking point. The modern lung protective strategy has a totally different goal: to minimize ventilator-induced lung injury, or VILI. We do this with tiny tidal volumes, 4 to 6 mils per kilo of predicted body weight. That's based on height, not actual weight. And we religiously keep the plateau pressure below 30. We accept that the CO2 might rise a bit, so-called permissive hypercapnia, because we know that protecting the lung is more important than a perfect blood gas. To really understand why this works, you have to understand the physiology. The main reason patients with ARDS are so hypoxic is because of intrapulmonary shunt.
Their alveoli are full of inflammatory gunk, so blood flows right past them without picking up any oxygen. As you can see from this table, the defining feature of a shunt is its poor response to supplemental oxygen. You can put the FiO2 up to 100%, but the sats just won't budge. The oxygen simply can't get across that roadblock of fluid and debris. It's like trying to get more cars through a tunnel that's completely blocked. It just doesn't work. This is why we need strategies like PEEP to try and recruit and reopen those collapsed, flooded lung units.
Now, mechanical ventilation is life-saving, but let's be honest, it comes with a pretty hefty price tag in terms of complications. Having a tube in your throat bypasses all your natural defenses, so ventilator-associated pneumonia is a constant threat. We've talked about barotrauma from too much pressure. From a cardiovascular point of view, the positive pressure in the chest squeezes the heart and great veins, which reduces venous return and can drop your cardiac output and blood pressure. And of course, the longer a patient is sedated and paralyzed on a ventilator, the weaker they become. Their diaphragm wastes away, leading to the huge challenge of weaning them off the ventilator later on.
Okay, let's bring all this together in our final section. We're going to look at the sharp end of clinical practice, the most current evidence-based recommendations for managing sepsis-induced ARDS, taken straight from the 2021 Surviving Sepsis Campaign guidelines. This is what best practice looks like today. One of the most powerful interventions we have, and one with a strong recommendation in the guidelines, is prone ventilation. The evidence is clear. For patients with moderate to severe ARDS, turning them onto their front for at least 12 hours a day improves mortality. It's not just about improving the oxygen levels. By proning the patient, you use gravity to your advantage. The heavy, waterlogged parts of the lung fall forward, allowing the larger dorsal lung regions to open up. This improves ventilation perfusion matching and reduces ventilator-induced lung injury. It's a simple concept with a profound effect. This table really summarizes the whole lung protective bundle of care for sepsis-induced ARDS. We've got our 6 mL per kilo tidal volume and our plateau pressure limit of 30. The guidelines also suggest using a higher PEEP strategy. The idea here is to keep the alveoli open, preventing them from repeatedly collapsing and reinflating with each breath, a phenomenon called atelectroma, which is incredibly damaging. We've just covered proning, and an interesting point on neuromuscular blockers. The guidelines now favor using intermittent boluses over a continuous infusion. The rationale is to use the absolute minimum dose needed to stop the patient fighting the ventilator, which hopefully reduces the total drug exposure and helps to mitigate that profound muscle weakness down the line. But what happens when you've done everything? You've got them on low tidal volumes, you've proned them, you've optimized their PEEP, and they're still dying from hypoxia. Well, this is when we consider the ultimate rescue therapy, veno-venous extracorporeal membrane oxygenation, or VV-ECMO. This is truly the last resort. The criteria are incredibly strict. You're talking about profound refractory hypoxemia or a life-threatening respiratory acidosis despite you having done absolutely everything else correctly. And it's crucial to note that for sepsis-induced ARDS, the guidelines give it only a weak recommendation and stress that it should only ever be done in a highly specialized, experienced center. It is not a magic bullet. We have covered a huge amount of ground today, all the way from the basics of stiff lungs right up to the most advanced critical care interventions. And as we finish, I want to leave you with a question that looks to the future. Thanks to these evidence-based strategies, we're getting much better at keeping patients with ARDS alive. But survival isn't the only goal. So the next great frontier is this. How can we best individualize the process of weaning from the ventilator to not only ensure survival, but to improve the long-term functional and psychological outcomes for the people who live through this devastating illness? Something to think about. Thank you very much for your attention.